All right, and we welcome in our live streaming audience. The live stream has been turned on, so we can go to the next slide. So we have an action-packed agenda for our open session today. Our president will offer a quick welcome. We'll talk about the OPTN budget, fee recommendation, and policy project updates. We'll have a discussion around the transfer of the OPTN reserves. We'll then move into voting on the proposed FY26 policy project proposals and to voting on moving those to public comment. Then we'll have a discussion around the extension of the current pause on routine surveys for the first 6 months of FY26. We'll have an update on our OOS, update on AOS work group, and then we will talk about a quick announcement of the updates to the summaries of evidence for two topics that were discussed at last week's executive committee meeting. So that's our agenda for today. We can move to the next slide. So given that we've had a few board members join since we started the closed session, we're going to take quorum again. So if you all can complete the quorum link that is located in the chat, that would be greatly appreciated. And then we will move forward once we know that quorum has been reached. Okay, quorum has been reached. So John, I'm going to turn it over to you to offer us a brief welcome.
Great. Welcome everyone to the August Board of Directors meeting. The current board has been working hard, looking at the finances, our income, our costs going out to support the various missions we've been charged with doing, as well as things in the future we're working on. So that'll be a big item today. Dr. Reed will be, our treasurer will be presenting some of that. We will also be talking about 6 proposals that the board will decide to approve or not approve to send out for public comment. Those were previously reviewed in the past board meeting and in the board members' drop boxes. So don't want to delay things. We've got a lot to talk about. So back to you, Tennille.
Thank you. And now I'm going to pass it over to Alan, who's going to discuss our first agenda item, so we can go to the next slide. So Alan, I will turn it over to you.
Yeah, thanks everybody, and good afternoon. I apologize to those who were on the closed session that heard all of this before with a lot of editorializing in between. This will be a lot simpler. My goal in the open session here is to talk about the budget, why the budget needs to be changed, and what recommendations we will make to HRSA and ultimately to the secretary to cover the cost of the work that is important to all stakeholders in the ecosystem. Next slide, please. Okay. The prior board at its June 2025 meeting approved a budget of about $74.5 million. That budget assumed a 5.5% fee increase. We currently pay a registration fee for every patient who gets placed on the waiting list, and that fee is $868. The prior board, in order to reach its budget number of $74.5 million, recommended an increase in that registration fee to $916 per registration. This was sent to HRSA for review as part of the FY26 budget. Unfortunately, the approved budget did not include expenses that were associated with a number of things. It did not include expenses associated with secretarial directives and HRSA directives, which are must-dos, and other OPTN initiatives that the Board Executive Committee thought were important and should be prioritized. I'll share some of those with you on another slide. To sum it up before we get to the math, basically, in order to achieve all of those things, the fee would have to increase to $1,035, which is roughly a 19% increase from what we're currently paying now. Next slide, please. Just to put this in perspective, the prior board in their FY25 budget actually approved and sent for approval to HRSA and the secretary an increase of $1,020 to $1,025, which is right in the ballpark of where our current ask is. But this was not accepted. And despite inflation and despite medical inflation, there have been no fee increases that have taken place over the last 4 years, while at the same time, the amount of work, the amount of previously unrecognized costs have gone up. That's really what's driving this request. Sorry, my lights go off if I don't move enough. There we go. Okay, next slide, please. These are the expenses that were not included in the prior budget, or the budget that the prior board approved. And they include directives from the Secretary of Health, directors from our colleagues at HRSA, other initiatives and things that we think are high priority, and some things that just have to occur, like cloud migration. I won't go over all these individually. You can do those. I will point out that there's been a lot of litigation, and those fees add up, and that cuts into our ability to do the work of the OPTN. But the total expenses of all of these things in the FY26 budget year is about $8.9 million. So, if I can have the next slide, please. Doing the math, if you look at what the previous board approved at $74.5 million, add the $8.9 million of the from the secretarial HRSA directives, as well as things that sort of have to get done, like cloud migration and other things the board thinks are important, you get to a total adjusted budget fee of $83.4 million. Subtract out the $6.5 million appropriation paid directly to the contractor, and you come up with a number $76.9 million. Our colleagues at UNOS provide for us an estimate of the number of registrations in any given year. And if you divide the adjusted budget of 76.9 by those 74,000 some odd registrations, that's how we come up with the registration fee of 1,035, that 19% increase. And this is our only source of income. With this money, we can do the work of the OPTN. This is separate money than what HRSA also spends on their individual contracts, like contracts with board support, contracts with SRTR, discovery contracts, and the like. But importantly, this is the money that we get to do the work of the OPTN with. Next slide, please. Okay, I will talk a little bit about policy project updates, but mostly from a financial point of view, because I think John is going to talk about this in more detail, and there will be some votes required later on. Next slide, please. So one thing that this incoming board learned, and it was not a very hard lesson to figure out, but a hard one to take, was we didn't have all the money we wanted to do the projects, because the prior board had committed monies to other projects that were in various stages of their life cycle. I think it's unrealistic to think that any project is going to get thought about, researched, implemented, and studied in a single year. And it's very hard to put the entirety of the cost of all those different phases on one budget. So one thing we've asked UNOS to do, and they've been very cooperative in doing so, is trying to estimate the cost of each project in different parts of its life cycle. And that will allow us to get a little bit more granular. But this $1.6 million comes from previously approved projects whose phases are going to hit the FY26 budget. So we have to be cautious of that. And going forward, we want to be able to plan for that. And that's what that granularity will allow us to do. Next slide, please. In a little bit, John is going to ask you to vote on individual projects that we would like to send out for public comment. These are those projects, and you'll notice that the entire cost of this work that will hit the FY26 budget is about $2.5 million. This does not include those two things that are crossed out, the data collection on NRP, NMP, and expedited placement policy. But rest assured that these things are important. And in fact, expedited placement policy is something that is being taken up by a different work group. You'll hear from Justin about that. So work on that will continue. And we all realize that collecting data on NRP and NMP are critically important for patient safety and donor safety going forward. And we are just waiting for other projects to finish to inform some of this stuff and make sure that we take on all aspects of that project before pushing it forward. But you will see that listed on the next slide as something that we need to consider for the coming year. Next slide, please. Tennille? Tennille, would you like me to go through this, or is this something that AIR
Yeah, I
will
think
take care of?
John is going to go through this. So at this point, we are going to take a vote on the OPTN fee recommendation, so we can move to the next slide.
And as that's happening, I just want to remind everybody that what we're doing is we're voting to suggest this fee increase to HRSA and the secretary, and ultimately it's up to them to approve.
Perfect.
Next slide, please. So the fee recommendation increase is 19% and 1,035.38, just to remind you. Next slide, please.
Right. So the question is, and as I believe Alan said, this has also been, in addition to being reviewed by the board recently, it's also been reviewed by the executive committee of the OPTN board. Okay, so the motion before us, or actually I think the Tennille, we need to have somebody make a motion for this, correct?
That's
And
correct.
so we've worded it as such, but this basically says that the 19.28% fee for fiscal year 26 as the final recommendation, updating the previous recommendation from the board.
As the board treasurer, I make that motion.
I'll second.
Second.
Any other discussion? All in favor?
Great. So we're going to put the voting link for this vote into the chat box. You should see it in the chat box now. If you are joining us only by phone, you have two options to vote. You can come off mute and let us know your vote, or you can submit your vote via email to optnboardsupport@air.org. And we'll just give folks a minute or so to vote. All right, we're just waiting for a few more votes to come in. All right, so the results of that vote were 29 approve, 1 reject, and 0 abstain. So we can, this passes, and so we can move on to the next slide.
So the next item we're going to talk about is transferring OPTN reserves. There, as has been discussed, there are reserves specific to funds collected through the OPTN fees in the past. Those funds currently sit in an account at the OPTN contractor, and moving forward, we need to move those reserves to HRSA so we can continue smooth operation of the OPTN. Again, these are OPTN funds. Where they sit, the board is responsible for both, but we can't make it work without moving these funds to a place we can access them. Next slide. So pursuant to the OPTN management membership policy, the HRSA is requesting mutual agreement in writing from the OPTN board to release all the funds from the OPTN reserve accounts to the OPTN primary account. Again, the reserve account currently sitting in the OPTN contractor, and the OPTN primary account will now sit with HRSA. As is highlighted by this statement as well, this highlights that these are our funds because we're the ones that they're asking to move them. And there will be continued transparency of both the burn rate and the annual amount. And that transfer is crucial so we can continue when the new collection starts. As Alan pointed out, getting the new fees collected will take some time, and the first month of it might not be as much cash in as we expect. So reserves are good for any business. Next slide. So the vote is there's a motion to the board authorizes the release of all the funds that are in the OPTN reserve accounts to the OPTN primary account. And furthermore, the OPTN officers are hereby authorized and directed to take any actions as they deem necessary to carry out the release of funds pursuant to these resolutions.
I'll make this motion, John.
Any questions from the actually, sorry. Okay, Alan, motion second.
Second.
Thanks, Cody. Any discussion? Any questions?
All right. The voting link for this, the transfer of the OPTN reserves has been put into the chat. Please click the link and place your vote. Again, if you're joining us by phone, feel free to come off mute and let us know your vote or submit your vote via email. All right, we're just going to give it another 30 seconds or so to allow people to put in their votes. All right, for this vote, we have 28 approve, 2 reject, and 0 abstain. So thank you all for your votes, and we can move to the next slide.
Great. So the next item concerns a series of policies that have been advanced by specific committees within the OPTN. They've been reviewed previously at the last board meeting at a high level, in addition to the documents being available in the drop boxes. So the process here is what we'll highlight high level review of what they are. The vote will be to send them out to public comment. We can also not send them out to public comment. It's a yay or nay vote. After the public comment period happens, they would come back to the board and the committees, be reworked as necessary, and then there'd be a subsequent vote for actual implementation. But if for some reason we thought something, there was no way we'd ever think it would be implemented, we probably should, we can change the course of the process here. But again, these have all been previously presented to the board. So next slide, Tennille. The first proposal has to do with HLA updating to 2025, sponsored by the Histocompatibility Committee. It had a benefit score of 91 using the system that we have at present. And the goal is really to optimize organ use. The Policy Oversight Committee recommended expedited implementation of this policy, and the POC vote was 12 yes, 0 no, 0 abstain.
You can go to the next slide.
So the motion is to, you can read it there. If I can have somebody make a motion to support this.
Hi, this is
John, can I
Kathy.
have, oh, I'm sorry, Kathy, go ahead.
That's right. I was gonna make the motion to support this.
Okay.
John, I had a question first.
Yeah,
Or
Andrew.
maybe more of a statement. So at least in Region 5, this is going to go through expedited discussion. So I don't think we're going to get much back for public comment. If we're looking for areas in the budget as we go forward for consideration of places to save, given that this is $85,000 and we heard from the Histocompatibility group that there are already existing workarounds for dealing with most of these issues, this is something we should consider as something to not advance.
I agree. We actually also had some discussion about what is this is this an annual thing? We're updating something that we have other ways of dealing with, or, they also mentioned some regulatory components, but I agree with your comment that it's other comments.
Hi, it's Kathy again. I would just like to say that we're mandated by the bylaws to update the HLA equivalency tables annually. So this is something that we're tasked with to do. And when I sat on the committee, we did that, but it takes 2 years, basically, as you know, to get this through policy to update these tables.
Thanks, Kathy. And this would also be an example, depending on what benefit we're getting. The bylaws can be changed if it makes sense. But if it, we should do the best thing for the patients and the community. Other comments? Tennille, did we have a second on that?
I'll second the motion.
There was a second.
Okay, all right, great. All
Yep.
right, hearing no further, I don't see any other discussion, no hands raised. The link is in the chat for this motion.
We'll give folks a minute or two to submit your vote.
Just for clarity, I'm wondering, I think the question Andrew wrote up is an interesting one. The amount of money associated with this in the budget, does that include implementation costs, or is that just the cost for sending this out to public comment, gathering the comments and reporting back? If somebody from HRSA or UNOS knows, that would be super helpful. It's my assumption that sending these things out for public comment is fairly low cost, getting the information before the board decides whether to implement or not, and not necessarily for this particular project, but projects in general.
I don't have the answer, but I would, it's a great question, and I would hope it's the total cost of pulling this off. Right.
Hey, apologies, my camera's still not working. My understanding is that this is the cost to implement this, but I'll let, if there are UNOS staff on, they can speak if that's incorrect.
And Lindsay, in case you can't come off mute, just put into the chat that the estimates and the proposals include the total cost of the project. So throughout the life cycle. Go ahead.
So to Andrew's point, we can, not necessarily this, because this is probably required and the cost is probably in programming, but the number you see includes not only sending it out for public comment, but the cost to implement, or at least the estimate of the cost to implement. And, if we have serious concerns about a particular project, the board can always stop it before it gets sent out for implementation.
All right, and I want to give you all the results of that vote. We had 27 approve, 2 reject, and 0 abstain. All right, so we can move on to the next slide.
So the next policy update is regards improving efficiency in living donor data collection, proposed by the living donor, or proposed initially by the Living Donor Committee, and they're the committee of support. The POC benefit score was 93. They're seeking to incorporate data on potential donors who do not donate into data collection and transition long-term follow-up responsibilities to the SRTR. And the POC feedback is listed there. They believed it was extremely important and well-intended to understand the gap between those who are interested and ultimately pursue a donation, some concerns about feasibility and public comment, or some concerns about feasibility, so public comment will be very important in this. They thought it was very important to get more input from the community about unintended consequences, etc. The POC vote was 12 yes, 0 no, 0 abstain.
John, just quickly, I want to point out a comment that Lindsay made in the chat in case others can't see it. It says, assuming the items are approved for public comment, estimates will be updated and provided again to the board for final approval to vote to move it to implementation in December. So updated estimates will be provided.
So, and if the good point, and if something is made simpler through this process, hopefully costs will go down. And if we make it more complicated, I'm guessing they're going to go up. All right. Next slide. So the vote is to follow the recommendation of the POC that the board approves this project related to updating and improving the efficiency of living donor data collection to move forward to public comment. John Hodges.
I would like to move this. Thank you.
Okay, thank you.
Second.
Ryan. Oh, great. Awesome.
I just wanted to mention, this seems like one that does need to go to public comment, but I think the POC correctly identified, I think there may be a lot of challenges with implementation and a lot of need for individual center resources to try to track all the potential donors. And so maybe something that we need to really evaluate closely, both the costs of the OPTN and the costs of the centers prior to implementation.
Yeah, agree. I don't think the current board, or at least I do not have extensive experience like slugging through what's likely a diverse group of public comments. So we'll need to make sure we pay attention to those closely. Any other further discussion about this motion that's been seconded? Again, advancing this to public comment. Hearing none. Tennille, can you put our
The link to vote is now in the chat for you all to complete. And just as a point of notice, the results that we share on the on this meeting are preliminary. So we are, like I said, we're receiving some email votes as well, but they may not come in as quick as real time via the World Wide Web. So we will be updating some of these results as the email votes come in, but it is not swaying the decision point for those. So just wanted to make sure that that was clear to everybody.
Thank you for that clarification. So and did we share the results?
Yeah, I'm gonna share the results once we have it. So we just received the results. It's 28 approve, 1 reject, and 0 abstain.
Great. Thank you.
All right, we can go to the next project.
So this is regarding guidance for pediatric heart transplant exception request to address a temporary shortage in equipment related to mechanical circulatory support. There's no benefit score assigned because it's to address a shortage that is there and is, I believe it's an extension of a pre-existing guidance. Am I correct?
Lindsay or anyone from UNOS, do you want to comment on that?
Hi, this is Lindsay. I apologize. I just missed a question.
This is an extension of something that had previously been approved?
So this was approved by the board in June as an emergency action. So this is going out for a retrospective public comment.
Okay. No, that's perfect. Thank you. Ari, yeah.
Lindsay, it might be helpful for the board to understand like why something would be put out for public comment retrospectively, if you want to explain that quickly.
So, sure. So I'm maybe not the best expert in this, but there is a bylaw provision or membership policy provision that allows for emergency actions. And so the board approved this to be an emergency action, so it was implemented immediately. However, there's still cause to receive public comment on the item just in case there were any unintended consequences with that implementation. So even though it was an emergency action that was implemented immediately, then we still want to receive public feedback on that action.
We can certainly, to Neil and the OPTN board support team, can you write down those comments too? Because it'd be great to not do things we don't have to again. And if we need to change bylaws to, I don't know, our plan is this year is to take a hard look at the bylaws across many things. So
No, we'll note that down. Thank you. So we can go to the next slide.
So the motion is here that the project is going to go out for public comment.
Can we get someone to
I'll
put the
second
motion
that.
on the floor?
I'll make the motion then.
Thank you.
Second.
Thank you.
Perfect.
Any further discussion?
So there is one question I think Dan had, which says, what is the process of sundowning a policy once FDA approved devices are available for this population?
Yeah, I was just curious. I can't raise my hand for some reason, but I was wondering if over time, and Ryan will know how far we are from that being a reality, but would this policy be kind of removed once there are devices available?
Yeah, so this is Lindsay again. I don't have the proposal directly in front of me, but I believe when the board voted on it in June, there was a provision within that resolution for the committee to sunset that update, I believe in July next year, but I can't be confident in that. But there was an end date to that change.
Great, thank you.
Good question. So we've had any further discussion?
All right, the voting link is in the chat. So we are currently voting on the modified guidance for pediatric heart exception request to address temporary mechanical circulatory support for the equipment shortage. And I'm reading that for the benefit of the individuals on the phone. So I'm sorry that I had to go through that. But so the link is in the chat for you to submit your vote.
While the vote is being tabulated, I have a question for Ryan. Do you have since this is a supply chain issue, it sounds like, do you have any idea how long this is expected to last?
That's a complicated question. I was on the phone with the president of Berlin Heart America earlier this week. The challenge is that they're changing the drivers. They don't want to produce more of the old drivers, but they don't have enough of the new drivers, and the new drivers are not fully FDA approved yet. They're still under an access provision. So it's not entirely clear when that's going to be all solved, to be honest. I would guess by sometime next year, hopefully. There are actually some alternatives. They're not FDA approved for long-term support, but they are used for long-term support.
Just waiting for the final results.
Oh, the other issue with it, I mean, ultimately, Berlin Heart, like the company, just doesn't make a huge amount of money, as with most pediatric medical devices, and so it doesn't run in the way that a typical company would, I would say.
Okay, we have the results of the vote. It was 28 approve, 1 reject, and 1 abstain.
Thank you.
All right, we can move on to the next slide.
So the next comment, or the next item to be advanced, if we approve it for public comment, is changes into the West Nile virus testing, which is seasonal, and it's been advanced by the DTAC. The benefit score was thought to be 53. There is a requirement that we do need to do testing for West Nile virus. the POC reviewed it. It was also discussed at the last board meeting. There was discussion about, you know, epidemiology, local geography, global warming, a bunch, you know, clinical risk factors, which could all be potentially involved. But at the end of the day, it is advanced as a specific set of dates and times. The POC added that, you know, the number of deaths from West Nile encephalitis is, we could understand that better. Adding opportunity is whether or not the seasonal testing adequately covers for OPOs and regional variations. You know, at the end of the day, I think that will be one of the values of public comment. We probably also need to have a policy that's enforceable, not just, you know, local zip code level type stuff. So next slide. So now therefore be it resolved that pursuant to the recommendations of the Policy Oversight Committee, the board hereby approves the project entitled Require West Nile Virus Seasonal Testing for All Donors and directs that this project shall be released for public comment.
So moved.
Thanks.
Second.
Okay, thanks, guys. Any further discussion? Look forward to the public comments. Okay. The
Great.
link is
Yep. The link is in the chat. And this is for the Require West Nile Virus Seasonal Testing for All Donors policy project proposal.
I thought I did a good job reading that for the people on the phone. I hadn't really thought about that. Is that should be standard?
Yeah, I think it would be beneficial when we know we have folks on that are only joining by phone, just to make sure that they know what they're voting on. But
No,
yes.
I hadn't fully appreciated that.
Yep.
Okay, thank you.
All right, we're just waiting for the results to come in. We appreciate everybody's patience today because this is definitely a very vote-heavy board meeting. So we appreciate your patience.
And we're looking into more efficient mechanisms of quorum determination and voting.
So the results for this vote are 28 approve, 1 reject, and 0 abstain. So thank you, everyone. And we can move to the next slide. Oh, John, you're on mute.
Sorry. The next comment has to go to be considered by the board, has to do with establishing a comprehensive multi-organ allocation policy. It's been advanced by the multi-organ transplant committee. Benefit score was felt to be 81, and it really standardizes how the organ offers match runs interdigitate in the setting of multi-organ donation. The goal here is really to optimize organ use and make sure it's done consistently. The POC recommended or supported it going out for public comment based on the review criteria. They felt it was important, well-developed proposal. It's been developed over several years with a lot of people's hard work. The concerns are it'll be tough to model it, and it's going to be complex. However, the POC felt that the multi-organ committee did a deep retrospective analysis of everything that could be known, and post-monitoring is going to be essential, just like with any policy, just to make sure we don't have unintended consequences. The POC vote was 12 yes, 0 no, 0 abstain.
All right, we can move to the next slide.
So I don't know if we should mention it now. Dan had a good question about, is there any, it's clear there are going to be groups that will not get the organ that might otherwise get it, highly sensitized candidates, pediatric patients, etc. So, which is currently a problem that just gets worked around through a variety of mechanisms. But I think that will figuring out who gets what when is going to be key. Andrew.
Thanks, John. I just have a question that we briefly touched base on with this, but given that there may be implications for allocation out of sequence, and the same reasoning for pausing continuous distribution may also be enacted if this goes forward for public, or if this goes forward for implementation. Are we sure we want to spend money right now having this go out to public comment if we don't know that we're actually going to be able to implement it?
Yeah, I think that's a great question. Clearly, we will both want to know how it interdigitates with the allocation out of sequence, as well as all the IT solutions that we don't really have a great grasp of. So I think the pre-implementation vote will be critical. I don't know what the record has been for cycles of out for public comment, but Shelley?
Yeah, I think the challenge, this has already been out once for public comment and now is being revised based upon that feedback for the next iteration. The reality is there was a comment about, weren't we going to pause this since CD was paused? And because obviously as CD gets implemented, this will be modified again as each organ goes on to CD. But I think there are enough questions going on about, when or how will CD be for the other organs? Are we going to change that? The future is unknown as to what's going to be the best mechanisms. And this deals with the now. The reality is right now there is no quote unquote fair allocation because every match run is run independently. And then it's sort of up to the OPOs to figure out, do I look at that match run first or this one? Do I look at organ A or organ B? And so there has to be some starting structure. And that's why it's so complicated, because we're bringing all organs together in this. And yes, it will be a continual revision over time as each organ changes the way they allocate, but that will be ongoing forever. And so interdigitating all of those organs together has to get started so that then it can be refined going forward.
Justin?
Didn't we have this discussion earlier and decided we thought it was prudent to bring this forward just to gather the data at this time, even if whether or not we were going to implement it because of all the work that's been done thus far, to at least capture it at this stopping point if it's not a continuation point? Thank you.
Yeah, I believe it was, and I believe there wasn't consensus.
It would seem to me that submitting it for public comment will actually add more voices and more points of view that, that this small group can't come up with. So I think it'll inform the decision a little better. So public comment, I see that as an easy way to just get more data.
Except that we're spending money on something that may or may not be enacted and then may be revised again.
Yeah,
and we're being told about budgetary constraints.
It's true, but I think this is something that is it's a reality of transplantation, and it's something that's going to affect all other organ systems. So, I mean, I think
it's
value
increasing.
Data.
It's increasing significantly.
Yeah,
So we have to get a starting structure going.
To Andrew's point, I'll just reiterate again that sending this out for public comment does not commit us to all those implementation costs. And this can be rediscussed and reprioritized or relitigated at the next board meeting. That's the intent.
And this is a question out of total ignorance, but is there any role for the OPTN to issue best practices or guidelines rather than this is an approach to this that would be, because a lot of OPOs have something there. Is there any middle ground in us coming up with a consensus statement rather than making it formal policy in the continuum of this?
I can offer you my opinion, John. I think OPO practice, and this will not make me popular in the OPO community, is a lot of it's sort of within constraints, the Wild West. A lot of OPOs do what they want to do. I think the more that we can conform practice, the easier it'll be for us to monitor, easier for us it'll be to have definitions of what is and what isn't working. And I think it'd probably be better for patient safety. That's just my opinion. I don't know if there's a mechanism or not.
I would agree with Alan that policies there are even policies in place that are UNOS or OPTN policies that get interpreted differently across different OPOs, and it's incredibly frustrating when you have the same situation arise in two different places and you get two different answers. So I think the more granularity we can get around it, the better.
Yeah, I mean, I think there are policies. They are not clear, and some are, conflicting or really not well defined, right? There's SLK, but if you look up SLK in OPTN policy, if you control F and look for SLK, it doesn't exist. It's just on the match run, and there's no good way to train staff. So I really think, as we are leaders of the OPTN representatives, I would prefer that we quit calling it the Wild Wild West. There is inconsistency in practice because there is inconsistency in policy. There is a lack of training materials in policy, and we have staff that are doing this work at 2 a.m. With late declines and everything else. And so where there is a room to improve is in policy, and I fully agree with that. But I do think constant changes and lack of support and education when things change leads to inconsistency. And so that is where I also worry about implementing something and then 2 months later having the out of sequence group do work that then changes it again. It concerns me in having that consistent application of these policies. I fully agree we need consistency in policy, and sometimes it is we have no guidance, so who gets which kidney? We don't want to decide that, but tell us how it should be done. So I do think that there is absolutely work to be done in this realm, but I would like us to hopefully be more understanding of how we got here and the root causes. And it's not because anybody wants to be rogue, it's because there's a lack of guidance and different realities in different parts of the country.
Yeah, I agree. I agree, and accept the friendly amendment, withdraw my comment about the Wild West. But I will point out that the OPO people are not the only people up at 2 a.m. Maglioka and I and McGee are on the other end of that phone call. And I couldn't agree with you more that all of this is a result of a lack of integration and alignment in all of the stakeholders. And I think that's what we really have to get to the root of in our positions.
Yeah, a system that can actually make it very straightforward to follow the rules is the best option. Jen.
Yeah, I just wanted to say, I think this is an opportunity with the modernization for all of us to kind of come together, start from scratch, and build this moving forward with a new set of guidelines, policy, and everything moving forward together to establish this and really build something together cohesively. Everyone starting from a basis point. And I think this would really be setting the groundwork with this all together so we can all learn, work together, like Sam said, because everyone is kind of working independently. And that's not, doing anything on a positive note for the patients, for the OPOs, for the surgeons, and everyone is kind of fending for themselves and creating this chaos and this kind of discombobulation for everyone. And that's not benefiting anyone, patients, donor families, doctors, staff, anywhere. So I think we really have a place now where we can do this. And I think this would be really well received for the entire community at large.
Thanks, Jen.
Yep.
Any other comments? I don't see any. Danielle, do you see any?
Don't see any. So if we could have a motion to move this to a vote.
So again, for those on the phone, the motion is now therefore be it resolved that pursuant to the recommendations of the Policy Oversight Committee, the board hereby approves the project entitled Establish Comprehensive Multi-Organ Allocation Policy and directs that this project will go out for public comment.
Motion.
Thanks.
Second.
I'm so sorry, John. Can I just ask one more clarification about this? So if this goes out to public comment, are there zero financial implications of public comment? So there's no cost to having public comment done.
Well, I'm not the expert, but if my experience is there's always a cost. And so is anyone from the OPTN contractor available to ascertain both the cost of sending it out as well as reviewing it? You know, it's
Yeah, this is Lindsay. So for the estimates that we provide for these projects, public comment facilitation is included within the development phase of those projects. So any costs associated with public comment, whether it be administrative or committee support, with the evaluation of public comment, that's included within the development estimates.
and how much would that, you have a ballpark of what that is?
I don't have that offhand. It probably varies by project.
And Joe reviewing the public comments is free, so that's good. So
It's not free, it's a sunk cost. I'll just put it that way.
yeah, exactly. So we'll try. That's a great question.
I guess the only thing I can add there is the ongoing cost theoretically, which is under implementation, would be the MOT committee reviewing the public comment to determine if any further modifications to the proposal are necessary. So whatever that hourly estimate fee for contractor employee time, because obviously we're all volunteers, would be that versus pausing the MOT committee so that it's no longer doing anything.
Yeah, the great point, Shelley. The committee support is substantial and independent of like sending it out, because we're going to have to keep meeting. I thought I saw another hand raised, or was there a comment in the chat?
I think it was just a comment. It wasn't a question. So I think it was Vincent saying this work could and should be integrated into AOOS and CD work. So it's a framework for moving forward. So that was the comment. All right. I think if there are no other comments or questions, we can go ahead and put the voting link for this in the chat. It's there for you to submit your vote. Again, this is the vote on the established comprehensive multi-organ allocation policy proposal. And just as a point of order, while we're waiting for folks to submit their vote, I think we have one more project that's coming up for vote. And then we have two other presentations that we need to get through. So just wanted to put that forward from a timing perspective. And we have about 20 minutes left.
So next slide.
All right, and this results of that vote was 23 approve, 6 reject, and 0 abstain. So thank you all for your submissions. All right, we can move on. Let's go ahead, John.
Yes. So this is the final one, right, Tennille?
Yes, sorry, I was talking.
Okay, sorry.
Yes, it is.
Okay, good. So this comment has to do with notification of status change for patients on the wait list. The benefit score was 87 by the POC framework. The reviewers supported it going out for public comment. Extremely important for awareness of patients awaiting transplant. Aligns with the idea of patient-centric care, supports transparency, engenders trust and shared decision-making, and it's well-grounded in ethical principles and generally what we're trying to do. The POC vote was 12 recommend, 0 no's, and 0 abstains.
All right, next slide.
Can I ask a question?
Yes.
Just for clarity, I want to be sure that if a vote here is to send it out for public comment, but to vote against sending out for public comment doesn't grind this project to a screeching halt.
Interesting question. My
Lindsay, do
guess
you-
is
oh, go ahead.
no, my guess is it has to go out for public comment before it can move forward. So, Lindsay.
I guess I would say if you do not vote for this to move forward to public comment, it would be helpful to provide direction back to the sponsoring committee as to what they would need to reconsider for the project to bring it forward.
I just want, the board members to understand the ramifications of the vote. I mean, is this stopping a project from moving forward in its tracks? That's because as I was sitting here kind of reviewing these things and thinking about them, well, this is really kind of giving a stamp of whether we support this project or not. If we stop it from going out, it essentially kills it dead in the water.
John Spearville, sorry.
Yes, so I just wanted to remind everyone, I think Justin may have mentioned this in the last meeting, is that the Patient Affairs Committee, which is comprised entirely of patients, donors, and donor families, has spent an extraordinary amount of time on this, and it has overwhelming support on the Patient Affairs Committee, which we should consider going forward.
Agree. John Hodges.
This is regarding whether or not this kills the proposal. As Lindsay identified, direction for how it is not ready to go out to public comment would be what would be our responsibility. The process was not quite so carefully orchestrated a couple decades ago, and things did come to us that weren't really ready for prime time. And that's what got sent back. And it didn't kill the process. It was just a matter of saying, we don't think this is ready for the public to see it.
Good point. Good context.
Yeah, thank you. I wasn't suggesting that, I was, this particular item was something I think should be killed. I was really just thinking about the bureaucracy of it. That's all.
No, good to think about. Any other questions, comments? Did I read this?
No.
What, you want to take it, Neil?
Sure. Now therefore be it resolved that pursuant to the recommendations of the Policy Oversight Committee, the board hereby approves the project entitled Require Patient Notifications for Waitlist Status Changes and directs that this project shall be released for public comment. So we will go ahead and put the voting link for this project in the
So
chat.
moved.
Oh, thank you. I forgot that we didn't make a
Second.
motion. Thank you, John. Can we get a second?
Second.
Further discussion? All right.
All right, sorry. I was trying to move us along and was going too fast. So the link is now in the chat for you all to vote on this policy project. In the interest of time, why don't we go ahead and move to the next slide, and I
Yeah.
will come back and give us
No, that's
the
great.
results of the vote.
So
All right, so
Ray's going to
Ray,
give an update on the pause in routine surveys for the first half of the fiscal year. Ray.
Yeah, I definitely want to make sure we have time for Justin's presentation on AOS. So if you go to the next slide, please. This is, I think, an easy decision. We've reviewed with the operations contractor, we've reviewed what these surveys have normally turned up. They have not identified high acuity or urgent patient safety needs. And so deferring these right now is a good use of resources.
And the officers had seen this previously and I think supported. And
John Hodges.
Yes, so this will come up again in December, or?
the unpause mechanism, right, would be.
Yes, and we can rediscuss the frequency, whether 3 years is, now that we know that this may have some, marginal value, but is 3 years a good cadence for it is 4 or 5 better? Should it be predicated on other compliance or performance issues? All those things are open to debate. We just know that in the current iteration, it's not a good return on investment.
Thanks. Next slide.
John, do you want me to read this? This is a long one, so for the benefit of the group, it says, whereas pursuant to the recommendation of the Finance Committee, the board at its meeting on June 9th and 10th, 2025, approved a pause of routine site visits in the fourth quarter of fiscal year 2025. And whereas the board has determined that it is in the best interest of the OPTN to extend the pause of routine site visits for the first 6 months of fiscal year 2026. Now, therefore, be it resolved that the board hereby approves the extension of the pause on routine site visits for the first 6 months following the end of the fiscal year 2025, beginning on September 30th, 2025, and remaining in effect until March 31st, 2026. Further resolved that the board specifies this 6-month extension shall apply only to routine site visits and not to any other type of visit, including but not limited to visits conducted in connection with allegations of safety and or non-compliance with OPTN rules or policies or applicable law. Further resolved that the board requests the OPTN to issue a general compliance communication summarizing the most frequent issues identified during routine site visits conducted over the past 2 to 3 years in order to promote awareness and support ongoing compliance efforts.
So moved.
Thank you. John Hodges.
Just wondering if there's a date certain for that report of the general compliance communication summarizing.
Ray, do you have any insight into the timeline for that report?
No, we can get back to you on that.
Okay.
Thank you.
Second.
Thank you. I heard the second. Any other questions or comments?
I just have a quick comment I'd like for the record is that I think this needs to be communicated effectively to the transplant hospitals, to those other than members, as this is a major concern for the transplant hospital, for who the donor hospitals are. That this will feel like there's not oversight of this process, and with the increased concern of whether we are doing things appropriately and ethically is a major concern for staff at those hospitals. So in that communication, I would just want it on record that we still want these things to be safe and ethical, and that there were other mechanisms that it sounds like are better to get this information, but that needs to be communicated very clearly, lest we lose potential donors.
Great point. Mary, would you also be happy to review the outgoing note about that? Because it is
very much. Yep.
Yeah, perfect. I really appreciate that. And again, these site visits are for the center, the programs, not the donor hospitals. But I think the more everyone knows, we're not abandoning this process. We're actually making it more robust in many ways and recognizing that this is not super effective, or potentially not super effective.
Thanks so much for that clarification, John.
Yeah, definitely. Thank you. And I welcome your help.
All right. The link to vote is in the chat, and we will take your, you can submit your votes there. Again, in the interest of time, I'll read the results of that vote at the end of the meeting, and we can move on to the next slide so Justin can give his update on AOOS. Justin?
Hey, thank you. Update on AOS. This is kind of in conjunction with the kickoff meeting I had last Friday. With most of the group members. Next slide, please. As a bit of background on this before I get into these, in August of last year, HRSA sent OPTN a critical comment letter that led to some work and some recommendations on allocation out of sequence. That critical comment letter addressed. In July of this year, HRSA then sent a more detailed letter back to OPTN on review of some of the previous board's recommendations with some proposals to move forward. One of those being to formulate a work group to go to work out on some of the problems with allocation out of sequence. I was asked to chair that group by John, and this is how I formulate it. And I'll say Jen Benson and Samantha Endicott kind of talked about some of the work that's going on, and in particular, Samantha talked about consistency and application of problems with OPOs. So I create a problem statement off of that letter from HRSA, and I think that really when you drill to the bottom, this is the issue with a lot of problems that we have right now, not just allocation out of sequence, but others that are kind of front and center right behind allocation out of sequence. So it's leadership and oversight of OPOs, not giving them clear guidance. And then as I state on this statement, where they develop local solutions to universal problems. So I think it's the task of this group to help kind of pull it in and make some recommendations to resolve some of those issues, with the objective off of that letter and off this group to reduce AOS. And there had been some questions about what that means to reduce. I think the work of these three teams that were created out of this, the Define Organ Offer team, the EPP team, and the OPO compliance team, will collectively make recommendations that should help reduce AOS. So after we talked about this problem, really with the scope of work, it was a really fairly large scope of work that was tasked. So that's how we ended up breaking into three teams. Next slide, please. This just shows the kind of the staffing of this work group. You've got HRSA and OPTN overseeing this group. I'm the chair. We have admin support from AAR, and we have permission through authority of HRSA to utilize other contractors to support this team. There are two chairs, and I thank them greatly for their, right now we have two chairs, Stephen Potter and Kevin Lee. I thank them for agreeing to join and lead teams. So Stephen Potter's leading the offer team. Kevin's leading the expedited kidney placement team. And then we're waiting for a third chair that between John McGee and I are working on to lead the compliance team. Next slide. So here's some of the tasks that came out of that letter, and then some of them that we have divided up. So if you look at, I'm not going to read all this, but I would just like to mention that we feel that some of the issues that the OPOs are having is not having a clear definition of an organ offer, which this team is going to do some research and look at, and describing the components of a compliant offer, the best components of it, reviewing policies, and then making recommendations to any policy revisions to how an offer is defined. The EPP team is going to look at expedited kidney placement. There was a critical comment letter from HRSA to OPTN recently on expedited kidney. That team will obviously work closely with the offer team. And then the third team is going to be a compliance team that's going to look at some of the things that the MPSC reviews, and also training and education from the OPTN, recommendations on training education to OPOs to ensure consistent application of how they do their business. As a chair, I'm going to monitor progress, initiate any course corrections, and then draft public updates, which I've got an initial one coming due soon. And then all of us are going to monitor that AOOS website that's already up to see if there's any feedback from stakeholders on any of these projects. Next slide. This is the framework I developed for this project. So the first step, which we're in right now, well, let's go behind that is team formation. We're just formed teams. We're forming the site, getting information out. So that's kind of the initial start of the project. But our analysis is just phase is just reading all the materials, researching. Then we're going to define refining problem statements for each of those three teams off of the broad statement that I developed for the project overall. And then developing solutions, validating those solutions through testing. And then we'll present those solutions to myself. And then they'll go to the what I'm calling the executive management, a team that's leadership from HRSA and OPTN for the OPTN chair for final review. And then to publish those results. And when I say publish, that doesn't mean necessarily that a document is published. It could recommend changes to policy. It could recommend updates to bylaws. It could be any number of things that would come out of this group. It's an aggressive timeline for this group, and we're just getting started. The team leads will have initial meetings with their teams in early September. Next slide. I believe that's it. Yeah. Pending any questions? Yes, Andrew.
Justin, thanks for your work on this. Obviously, it's a huge lift. Just some of the language I've been hearing, both in this meeting and I think in the way that this is being described as an OPO challenge, and that we need to have compliance on the OPOs and everyone needs to make sure the OPOs are working. Whatever else is true, I hope that this group takes into account that there is a lot of hospital, center, and provider level variability and willingness to assess certain organ offers, and that this has to be a broad consideration beyond just increasing compliance on the OPOs.
I agree, Andrew. I found that this is, like I say, those were my words, that problem statement about leadership of, I would say at this level of OPOs, but we've got those teams, there's a lot of providers on the teams, and I think that it will bring that voice to the table. There's OPO representation, there's patient representation, there's providers of all organ types on those teams, and the intent was to have all those voices coming in to say, hey, here's how we really are defining the problems.
And,
No, I
and there's
appreciate
still
that.
there's still the program can also decide what they which is not necessarily good. So I think it's got to be a holistic solution. You're 100% right.
Yeah, and that's not lost to me, Andrew. That was just kind of the start of the framework of the problem, but I realize how far that drill has to get down to really touch the depth of the problem.
Sam, did you have a question?
Actually, I think both of the things I wanted to bring forward is just, and I'm hopeful with the additional contractor support as well, because I think a lot of what has been discussed in the past regarding these issues has brought us back to the lack of dynamic tools in decision making, both for OPOs in following allocation policy and also for centers when new information is learned about the donor, maybe a biopsy comes back, test results come back. It doesn't have any impact on allocation because it's not dynamic, it's totally static. And so I'm really hopeful having additional contractor resources will allow us to take a more forward thinking approach and more dynamic approach to this really complex problem. But otherwise, I appreciate the comments of my colleagues because they were the comments I was going to make.
Hey, I'll add one thing to Andrew's comment, and don't believe that we're looking at OPOs and saying compliance. In my analysis of it is leadership of OPOs, the guidance and policy they get from this level and above too.
Yeah. Just a quick commercial. There's a HRSA OPTN allocation out of sequence website. If you didn't get the link to that, lots of material there that's worthwhile drilling down and potentially a future state of what information we might have in real time. Alan.
Yeah, in support of Andrew's comments, I think it's important to realize that not every allocation out of sequence is necessarily bad. And defining an allocation out of sequence as not following the recommended policy is tautological in the sense that it assumes the policy is correct. And so my comment is I'd make sure that we look at whether the allocation policy is part of this. It makes sense because, you know, everyone's acting in their own best interests, and sometimes it's just not appropriate to put a 68-year-old organ in a 17-year-old person, and you may want to get, if you have that ability, get down to the 65-year-old on your list who's going to do better with that organ. So those are just editorial comments.
Yeah, we just need to codify that.
Yeah, thank
better.
you. And the offer team is going to be getting after that to make sure that that definition of offer is proper. And we're not just looking at reducing allocations by squeezing out from what we have right now.
I would agree with Alan's comments that by and large, everyone is trying to do the right thing. And sometimes policies don't match the intent, and appreciate, Justin, you put this together, and the the fact that you're getting a broad group of stakeholders.
Thank you, Vincent.
Yeah. And again, this is hopefully a model of how we'll address things moving forward with larger groups, cross committees, bringing in some external members not on the OPTN committees, and again, partnering with HRSA and our contractors. So, all right. Tennille, do we have a hard stop or like?
No, we can keep going if
Okay.
folks are available.
I don't, this is not a long item, but basically this is informational. This is an update to summaries of evidence, which is a process by which a committee can update materials that are in support or lay the rationale for policies. Next slide. So again, provide updated information, review by experts. In the case of this set of things we're talking about, it's really donor-derived diseases. Are we being too restrictive? Are we being too not cautionary enough? And with the idea of maintaining patient safety while maintaining effective use of donor gifts. So the DTAC reviews these annually. They're presented to the executive committee, which they did last Friday. We vote to approve it, and that's the executive committee does, and then just replaces the information. Next slide.
Next slide.
So one has to do with SARS-CoV-2. The other has to do with Mpox. The material there is basically the same. They were reviewed, the information, quite an amount of work. I applaud Dr. Sarah Pouch and her committee for all they're doing to review this and make sure we're providing the most up-to-date information for our practice and to protect patients. Next slide. So no, this is all available on the website. Next slide. So really just informational. We can.
Next slide.
This is just the summary of the executive committee votes. The good news is that no motions needed here. Both were unanimously approved by the executive committee.
John. All right, we can go to the next slide, which is just announcements. And so as promised, I said that I would read the results of the last two votes. The first one was the patient wait list vote. It was 28 approved, 0 reject, 0 abstain. And for the extension to pause the routine site surveys, that was 23 approved, 1 reject, and 0 abstain. So thank you all for your votes. My one quick announcement is that for any board member who has not yet completed your COI training module, this is your just a reminder to do that before next month's September board meeting. So just wanted to share that with you all, and then also share that tomorrow we will be sending out our first weekly email to the full board. So be looking out for that. These are emails that are going to come out on a weekly basis to just make sure that the board is informed of what's going on in terms of OPTN activities and other key items. So yes, there was a question about the December in-person meeting. You all should have received the hold for that meeting. It is going to take place on Friday, December the 12th. We are working through the logistics of that now, and we'll be able to provide you all with some instructions on how to book your travel soon. So stay tuned for that as well. But you should have the calendar hold on your calendar. All right.
I wasn't sure if it was tentative. Thank you.
Yeah, no problem. All right, if nothing else, we appreciate all of your time and effort. We know this, like I said before, this was a very vote-heavy agenda, so we appreciate your diligence. And John, I'll turn it over to you for final words and adjournment.
No, I just welcome everyone's efforts here. Lots of good comments, both made in public and orally as well as in the chat. So keep the ideas coming. I think we will continue to finesse the machine that will help us work. So thanks, everybody.
Move we adjourn.
Second. All right. Have a good
Thank
night.
you all.
Thank you.
Thank you.